Are you all able to see my screen?
Yes.
Okay, that's great. I am just waiting for the live stream to start.
Benim bugün baktığım en saçma sapan sandalyeler böyle 400, 500, 600, 1000, 2000 olduğu için inan senin kitaplık ucuz geldi yani. İstiyorsan seni çok seviyorum.
Okay, all right. A very warm welcome to one and all present here. And I would like to welcome you all to this masterclass and overview to IVDR and its impact on digital health. My name is Jay, and I'm a communications officer at Medidia, and I will be a session moderator for today. Along with me, we have all the panel members who have joined in. So I would like to welcome all the panel members and all the attendees who have joined us on this Zoom call, and also who have joined us on the live streaming on LinkedIn and different platforms. So a big welcome to one and all present here. Moving on. Today's class, the agenda for the class is all about welcome and introduction to the session. So that's going on right now. Right after this, I will be inviting Lucy Campbell, who is the representing EIT Health today, and she is going to give an introduction to EIT Health and MedTech in EU. After that, we will have Greedil from Global Regulatory Services, who will give us an overview of the IVDR and the key changes happening as from 26th May 2022. Right after that, we are going to engage for a very short interactive quiz. So please please stay attentive and make sure you listen to all that's being told, because there is going to be a quiz moment, and whoever wins the quiz will be the winner of the day. After the quiz, we will be taking a short screen break, and then we will have David Didsbury from Medidia, who will speak about IVD, software as a medical device, points to remember. Right after him, we will be having Paul Butcher from Global Regulatory Services, who will talk about cybersecurity under IVDR. And last after that, we have a very interesting pitch from EIT Health Alumni Network, and Celia Cruz, who is representing EIT Health Alumni Network, will be giving us a very interesting opportunity. And then we will have plenty of time for question and answers, and we will try to close the session by 3 p.m. So please make sure that if you have any questions during the session, use the chat box to note them down, and I will pull them up towards the question and answer session. During this session, I would also request you all to please keep yourselves on mute and use the chat box to communicate for any questions that you have. You would have already received the presentation and the slide deck on your emails, and you can open those slides simultaneously so that it's easy and you know what slide we are going to do next. And right after the end of the class, you will be receiving an email from me again, and I will be sending you an IVDR checklist. This checklist is all aimed at assessing and analyzing if you are IVDR ready or not. So stay throughout the class, and then make sure you use the checklist. And then if you have any questions, you can drop us an email on mdd@mddltd.com, and we will be there to help you out with all your regulatory queries. Well, that's all about the introductory session. I will stop sharing my screen and I will invite Lucy Campbell from EIT Health, who will now take you all forward. Over to you, Lucy.
Thank you, Jay. How are you? Many thanks for the invite. So I'm sharing my screen. Can I just check everybody can see me loud and clearly?
Yes, we can see you, hear you, and we can see your screen.
Okay, perfect. So first of all, thanks for the opportunity. EIT Health are delighted to partner with Medidia on this IVDR Masterclass, and indeed it's such an important initiative and information session to really inform people in the medtech industry and beyond as to what is going to be the impact of the key changes happening very soon on May 26th. So I'm just going to give you an overview of EIT Health. So I'm the entrepreneurship lead for EIT Health Ireland UK. So EIT is essentially a European Institute of Innovation and Technology, and we operate with what we call multiple knowledge innovation communities, or KICs, of which we have 7. And EIT Health is the largest one of those KICs. So we were set up in 2015, essentially with a remit to train the new generation of entrepreneurs, to develop innovative products and services, and also to power startups and scale-ups. Our vision essentially is to empower citizens to protect their own health by improving healthcare systems through advances in education and technology. And we're already well on our way to achieve that mission to be Europe's leading health innovator by 2030. And we do this through facilitating networks and collaboration. Really what we do, so we have a collaborative partner network of 150 organizations, and we bring these organizations together from business, research, education and healthcare delivery. And what we do is we facilitate that international healthcare innovation network. And for startups in particular, we provide access to European markets, to investors, to stakeholders and broader knowledge networks. So within the overall EIT Health network, of which Ireland UK is one of what we call regional hubs, there are 8 in total. Our headquarters are in Munich in Germany, and Innostars, which is the final hub, just recently set up, looks after the Southern and Eastern Regional Innovation Network. So I think you could say that there's no area in Europe currently that EIT Health doesn't touch. And so anyone who joins or partners with our network gets access to the entire European health ecosystem and community. Just to give you a sense of, from the Ireland UK perspective, the partners that we work with in this market, our core partners are Trinity College Dublin, the Oxford Academic Health Science Network and Medtronic. And we have associate partners with Blue Metrics, who's a data and AI company based in County Cork, and NUIG over in Galway. And Galway's emerging as one of the predominant kind of hotbeds of medtech startups and scale-ups and innovation. But even across the wider partnership network, you can see that across medtech, biotech, digital health, and life sciences and pharma, there's many what we might call household names. So again, that's the power of the network across the entire European ecosystem. The team here in EIT Health Ireland UK, we span across entrepreneurship, business creation, education, innovation and communications. And I guess the purpose for the team here in Ireland and the UK is that we contribute to the Irish economy, and we're interested in driving job creation and supporting startups and scale-ups, but we're also facilitating that network for Ireland UK into the wider European ecosystem, and we also have a remit to influence European policy. In terms of impact, I guess, across the organisation, so Europe-wide, we've supported since our inception in 2016 1,200 startups, and we've also enabled 87 innovation-led products to be launched to the market. But within Ireland alone, Ireland and UK, we've supported 170 startups. And the investment that those startups have raised over the last, even in the last 2 years alone, is well into the nearly 400 million. So Ireland, UK definitely punches well above its weight in terms of the overall European ecosystem in terms of startup enablement and investment. Just to give you a sense of some of the success stories and some of the organisations who we have been delighted to support and are still supporting. So really, we've got Proverum, Celio Medical and Willola, and each of these startups, the founders have come through several EIT programmes to help them access new markets and networks in Europe. Both Proverum and Celio Medical, they originated in BioInnovate in Galway and are now affiliated into Trinity College Dublin. And in fact, Proverum has just recently closed a Series A funding round to the value of 30 million. And Celio Medical is making a lot of impact internationally. Sonia Neary, who's the founder of Willola, she's been through four EIT programs, and EIT, specifically EIT Health, has facilitated Willola's entry into the Italian market. So we've been delighted to support these startups and many more. And I guess essentially for any organizations that we're working with, we're really, through all of our programs and innovation calls, we're asking people really to focus on the six core areas. Obviously, to reform the care pathway, reforming care pathways to really help to prevent disease and optimize long-term care. We're also have a lot of interest in modernizing European healthcare systems and transforming healthcare. More and more, we're looking at the power of harnessing real-world data, AI, and really supporting sort of digital health startups in that regard. Bringing care home is a very important aspect of what we're trying to do and trying to enable through EIT Health to shift healthcare delivery from the hospital to the home. Health in the workplace is another core focus through education, improved personal awareness and access to healthy choices. And then obviously a lot of our work is focusing on encouraging a change in lifestyle behaviours by creating patient tools and incentives to prevent early ageing and therefore to foster healthier lives. So from an innovation perspective, we support the innovation pipeline really from end to end, from technology readiness level 1 right through to TRL 9. And we do this essentially through a range of early stage ideation, business plan, boot camps, pitch training, early stage education and entrepreneurship, right through to accelerating startups by offering exposure to international investors, offering collaboration opportunities with experts and bigger companies. And then we also support the scale up for people who really want to go on and find a market and build customers for their products and services. And essentially, there's a range of activities that all contribute to this innovation pipeline. So, for example, at the moment, we have a number of educational programs that are connecting researchers, both PhD and also postdoc, into industry so that they can really start to get the exposure and the experience that they require. And in addition to that, we've ongoing investor supports that will help scale up, such as Venture Centre Capital of Excellence, Gold Track, and a range of ongoing programs that have an ongoing entry across the year. All of this information, by the way, is on our website, and we also communicate regularly with our network through our social media platforms and obviously through email communication. Anyone who teaches EIT Health has the option to become part of the EIT Health alumni, of which we have 1,600 members growing every year. And I know Celia is going to give you the grand tour of the alumni network in due course. So I won't, I'll leave it there on that one. But just in terms of anyone who wants to become involved with EIT Health, you can join the alumni. We run a number of network engagements and events, most of which are open, so very similar to this one that we're running today. But also there's varying open calls, so where you can participate in education innovation programs and really help to join that. And really we encourage people to join our international network. So essentially, EIT Health is your pathway to Europe. As I said, eithealth.eu is our website. You can follow us on Twitter and also on LinkedIn. So I'm going to leave it there, but for sure would encourage anybody to get in contact with any of the team for any aspect of what I've discussed, and be delighted to talk further. Thank you, Jay.
Oh, that was wonderful. I am thrilled to see what EIT Health is doing, and I am definitely very much excited to see how the current participants of this masterclass will take the utmost advantage. Thank you again, Lucy, and the entire EIT Health team. And yes, as I mentioned previously, please stay tuned, because towards the end, Celia is going to give some interesting offer and opportunity. So do wait for that. Now, I would like to go on and invite Greer Deal to the podium. Greer, would you like to start sharing your screen, please? So Greer is going to talk about the overview of the IVDR and the key changes happening as from 26 May 2022. And yes, over to you, Greer. We can see your screen.
Okay, great. Thank you very much. Okay, perfect. So good afternoon, everyone. And thank you, Lucy, for that really fascinating presentation about EIT. It's wonderful to have such support for entrepreneurs right on our doorstep. So the more we can shout about that support, the better. You know, it's great to have that support. So I have 20 minutes to deliver everything about IVDR. So this is very much an overview. The detail of the impact of IVDR on digital health will be covered later by my colleagues Paul and David. So there's a key date here, the 26th of May 2022, which is literally just a few weeks away now. So just a very brief introduction to Global Regulatory Services, GRS. We are a global consultancy focusing on regulatory affairs and quality compliance across the whole of the life sciences. Of course, today's topic is very much diagnostics, and that's what we're going to focus on. The parent company, GRS, is headquartered in Cambridge in the UK. And a few years ago, we spun out a company, Medidia, which is represented here today. And that company is based in the lovely city of Galway in Ireland. And this gives, between the two companies, a footprint in Europe and in the UK. So we can cover those territories in terms of regulatory and quality compliance. The GRS business model is that we have specialists all around the world that can provide in-country expertise, as well as the technical, regulatory and quality knowledge that's needed for your medtech products. So we have a very good working relationship with all regulatory agencies across the world, and we utilise that for the benefit of our clients. Regulatory quality compliance, we don't work in silos. We very much are working with each other. So we work with market access, pricing, reimbursement, cybersecurity, lawyers, you name it. We have to be part of the ecosystem, and it's like a big jigsaw. You know, all those little pieces fit together. So regulatory quality compliance are pieces of that big jigsaw puzzle. So a few more services which are above and beyond the mainstream, what I call mainstream regulatory support. So in the UK, GRS can act as a responsible person for cosmetics and also for devices and diagnostics, which is obviously of relevance today. And then in Europe, for via Medidia, we can act as EU authorised representative. Person responsible for regulatory compliance, I'll touch on that a bit more a little later. Again, responsible person for cosmetics and clinical trial legal representative in Europe. And then in the USA, we also have US agents who can liaise on behalf of our clients with the US FDA. So now, the crux of the matter, the in vitro diagnostic regulations. I have put here Europe and the UK because very often people are looking at both territories. So regulatory affairs, why bother? Why do we have all these regulations? I know many of us think it's incredibly painful, very expensive, and creates an awful lot of work. But we're bothering because governments want to protect the public and public health. And to do that, they need to control quality, safety, and efficacy of the devices. It's interesting that they put it in that order. So quality is first, and that drives the safety of the product. And then finally, it's, does the product do what it says it should do? So we've already had medical device regulation come in. Key date, as I've mentioned, for in vitro diagnostic regulation is the 26th of May 2022. Great Britain, because Brexit happened in between the European regulations coming in, we've actually stayed with the UK Medical Device Regulations 2002, which in effect are the old directives, the old European directives. So IVDR, it's ringing in the changes. The old directive, when it looked at the classification of diagnostics, it was on a list-based approach of 4 classes. And it's list-based because they were literally listed in the directive. So general low risk, they're the ones that are so low risk that you don't need a notified body. So it's self-declaration. So examples of that are hormone tests, and actually of relevance is the SARS-CoV-2 test used by professionals. So that's the lowest risk self-certification. Then you've got list B, again, a listing. This is where a notified body is needed, and they will audit the technical documentation and your quality management system. Examples of that are self-tests for blood glucose and rubella tests. List A, which is the highest risk, you need a notified body, and they will review the design dossier as well as auditing your quality management system. And they will also do batch release. So they determine that what you're producing is what you have specified. So that's your highest risk. And then the last classification are devices for self-testing, so not listed. Again, you need a notified body, and they will review the design and labeling of the diagnostic to check that it's suitable for the user. So that's the old directive classifications. So shortly you can forget all about those because now we've got the new regulation coming in on the 26th of May 2022. Again, we have 4 classes of risk classification, but instead of being list-based approach, it's a rule-based approach. And basically in the regulation, there are 10 implementing rules and 7 classification rules, which will determine the risk classification of your diagnostic. So class A, again, it's very, very low risk. So it's the lowest risk you can have. And again, it's self-certification. So you do not need a notified body, or in Great Britain, you don't need an approved body. So that's low risk to the individual, and it's low risk to the public. So that will be things like lab instruments and containers, receptacles. Class B is moderate risk to the individual, and or it's low risk to the public. And they're things like thyroid function tests, fertility tests, pregnancy tests. Also interesting, class B, if you can't find a classification for your diagnostic in the regulation, then by default you become a class B. And a class B, you do need a notified body. You need to engage with a notified body. Class C is high risk to the individual and moderate risk to the public. And they're things like genetic tests and tests that check compatibility for someone to have a blood transfusion or an organ transfusion, something like that. And then class D is your very highest risk, and that's high risk to the individual and high risk to the public. So that'll be things for where they are testing for agents that can be transmitted in blood, readily transmitted. This is, if you remember in the earlier slide in the directive, I mentioned the SARS-CoV-2 test. This is an example of where you've gone from a self-certification, very, very low risk classification, but now under the new regulation, that becomes a class D, group D risk classification. In class D, there's an extra layer of enforcement almost, in that the conformity assessment needs the involvement of an EU expert panel, as well as reference labs are involved and something called common specifications. Actually, all of that is still to be developed, because not everything's been finalized with the regulation. So very important that you look at those classifications and see where your diagnostic comes in. Now, this image is courtesy of the BSI. I thought it was a really good visual of the different rules and, you know, the examples of diagnostics which could come in there, and you know where your diagnostic might be in terms of risk classification, so A, B, C or D. I've already made reference to SARS-CoV-2, and that is going to be up-classified as from the old directive to the new regulation. So you need to be very careful. If you've already got diagnostics on the market, you actually need to go back and revisit your classification. So I've said that the SARS-CoV-2 test self-declaration has moved up and been up classified to group D, your highest risk classification. Up classification means that if you're in the very low risk, you're now going to need to engage with an EU notified body. And this switch from the directive to the regulations means that at least 85% of diagnostic manufacturers are going to need to engage with a notified body. That's compared to 20% under the old directives. So it's a huge change. It's a real culture shift for the sector. So as I've already mentioned, you need to revisit your diagnostics if they're already on the market, and actually revisit your intended purpose statement, understand the complexity of the device compared to the implementing and classification rules of the regulation, and the environment that it's going to be used in. Is it going to be used in a lab? Is it used in the home and directly by the patient, so for self-use? Or is a professional going to be using it in a hospital environment? All these things add up to what your risk classification is. So we're talking about digital health, and when we talk about digital health, we're thinking about software. So can software be an IVD? Short form of software as a medical device, SAMD. Also, you'll see the expression of medical device software being used around Europe a lot. So MDSW for short. So when you're looking at your software, you need to look at the definition of an IVD in the IVD regulation, and it does cover off software. But you need to make sure that your diagnostic software meets that definition in order to qualify as an IVD. You also need to think about, does the software provide information which is based on data which has been obtained by a diagnostic device only? So that would then make that software a diagnostic. And is the intended purpose actually driven by IVD data sources? So if you answer yes to those questions, then absolutely yes, your software can be an IVD. So what else? I said this was a whistle-stop tour. So I've emphasized the importance of classification of your device, and that so many diagnostics are going to be up classified. And even if you're developing something right now, if you had thought that it was self-certification, double check, triple check, that actually it still is self-certification, because you may find it's actually been up-classified, and you're going to need to be planning to engage with a notified body and putting your quality management system in place. So with regards to the what else under the diagnostic regulation, what the regulation has done, in addition to the directive, it's actually brought about clarification on the obligations of the legal manufacturer, authorized representatives, importers, and distributors. Now, you may think it's pretty obvious what those roles are, but it's not always that obvious. And you need to actually have a look at where you and or your company is in the supply chain. So are you really the legal manufacturer, or are you actually the importer distributor and someone else is the legal manufacturer? So as you're all aware, many devices, diagnostics are made up of many components, and those components can come from anyone, anywhere in the world. So the regulation is all about control and mitigating risk. So you need to control the supply chain. And how do you control that supply chain? You need to understand all the roles and responsibilities of everyone in that supply chain that applies to the device, the diagnostic that's being placed on the European market. So determine who you are and where you are in that supply chain. The EU authorized representative, so if you're outside of Europe and you want to sell into Europe, you need someone, an organization, an individual to represent you in Europe to the authorities. Now, under the directives, it used to be that that role was more of a post box, so a point of contact for the authorities to communicate with, so that they can then communicate with the legal manufacturer. Under the regulation, it is made very clear that the EU authorized representative is now equally liable with the legal manufacturer for placing devices, diagnostics onto the European market. So what does that mean? Well, it seems pretty obvious that it's equal legal liability, so there's equal legal responsibility. It actually means that the EU authorized representative, their insurance must be at least equal to the insurance of the legal manufacturer in terms of public liability. So as part of your due diligence, you must make sure that your EU authorized representative meets all the requirements of the regulation, and also that their insurance adequately covers your devices, your diagnostics. Then there's a whole new role, person responsible for regulatory compliance. I've already mentioned that briefly earlier. So PRRC for short, completely new. There's about one paragraph in the regulation explaining what it's about. Again, there's minimum criteria for experience and expertise. But this is an individual who ensures on a day-to-day basis that a company is complying with the regulations. Now, if you're a micro or small company, as per the EU Commission definition, you can actually outsource that role. And again, you need to do similar due diligence activities with regards to, as I was mentioning, to the EU authorized representative. So a whole new role. That person should be doing regular audits on the company to check that there is ongoing compliance. There's more emphasis on the control of risk. So you've got your risk management plans. So you're always thinking about what if something goes wrong? What is the worst case scenario? So once you've identified all those risks, you then need to determine how you can mitigate those risks. So you're managing the risks involved with your diagnostics. And as part of that, to support that, you need to make sure you've got a really robust quality management system. Now, we strongly recommend that no matter what classification your devices are, you really should be complying with 13485. It's there, it's a standard, so many people adopt it, and there's no point reinventing the wheel and trying to create a system that is at least equal to 13485, which is what the authorities talk about. Now, the lower risk classification devices, quite a number of them don't go for a full-blown 13485, but I think in the future it's going to become more a case of that it is mandatory. And it's also going to help you engage with your customers, because they will be looking for that 13485 accreditation. So a lot more emphasis on quality management, and that quality management isn't specific to your diagnostic, it's company wide. So it's how your company operates and how they produce that the diagnostics, the devices, ensuring that quality is maintained. The other thing that is important to note is post-market surveillance. This is being, there's greater emphasis now on post-market surveillance. So once the product is launched into Europe, don't sit back and think, oh, great, that's all I've had to do. No, this is continually, you know, you're monitoring what is happening out in the marketplace. You know, what is the customer feedback? Are there any adverse reports? Do you need to do anything with those reports, etc., etc.? Then there's something called unique device identifiers, UDIs. That's down to traceability. So there's a lot of emphasis now on being able to trace every aspect of a device. And that goes back to control of the supply chain, really. And the unique device identifiers forms part of something called UDIMED, which you'll be needing to register on. And the purpose of UDIMED is transparency. You'll find across the world that more and more regulatory agencies are wanting to be transparent about about what they do, but also the companies that register with them and the type of products. Like you have clinical trial databases as well. So it's all about transparency so that anybody can have a look at that information. And finally, there's the clinical side. Clinical evidence, performance evaluation, performance studies, very specific to diagnostics. We're talking about performance evaluation. So this is about proving the claims that you're making about your diagnostics. So you need to be able to have clinical evidence that, or a performance evaluation, that what you're saying about your diagnostic is accurate. And again, if you look at all those boxes on the screen, it's not a tick box exercise. You really do need to consider this all of the time. It's ongoing. So it's a life cycle approach. So IVDR is date of application postponed. Date of application is the 26th of May, 2022. Absolutely not. It has not been postponed, despite everybody saying, please, you know, COVID has happened, we need more time. But the EU has agreed to have a long transition period. And like I said, that's because of COVID, but also very few EU notified bodies have been designated under IVDR. 6 notified bodies in Europe are designated. We have 3 approved bodies who include diagnostics in the UK. But if you look at the size of Europe and the UK, big difference. Although of course UK is still under the old directive. If you want to see which notified bodies cover what and what they're designated under, then search for NANDO and you can see a listing on there. So notified bodies, their role is they conduct the conformity assessments against the EU directives and regulations. So they review your technical documentation and of course your quality management system for certification purposes. There's huge changes, and that's again why they've agreed on a transition period. And as I mentioned already, at least 85% of diagnostic companies will now need to engage with a notified body. So it's a complete culture change. And you know, this industry is far more regulated now than it was under the old directive. So in Class A, the low risk products and any new products coming onto the European market will need to be compliant as from the 26th of May 2022, which is the date of application. So finally, the final slide, this is actually about the transition. So the soft transition, which has been agreed for all those reasons I've just mentioned. So 26th of May 2022, that's your key date. For all IVDs, your vigilance and post-market surveillance requirements do apply as from the 26th of May, okay? And all new IVDs in Class A, the non-sterile self-declared, they also need to be compliant from the 26th of May, as previously stated. If you have got a diagnostic already on the European market, which was declared under the EU directive before the 26th of May 2022, then you can take advantage of these soft transition timelines, as long as there's no significant changes to your diagnostic. So Class Ds have until the 26th of May 2025, Class Cs 26th of May 2026, and Class A sterile and Class B, these are all the classifications under the IVDR, have until the 26th of May 2027. So those are your key dates. And like I said, I shall leave Paul and David to drill down into the impact of IVDR on digital health. Thank you.
Well, that was really insightful. And with all the things that are going around IVDR right now, the information that you have just given to the entire audience is really insightful. And thank you so much, Greer, for giving us this lovely presentation. So until now, for all the audience members, as mentioned previously, there is going to be a little quiz round for you all. So I would request you all to kindly go to your mobile phones or maybe your laptops, and there is a link in the chat box, and you can directly go to that link and participate for the quiz. Apart from that, there is an option to go to ahaslides.com and you can put in the code 290322, which is today's date. Yeah, so put in today's date, that is 290322, and let's play the quiz and let's see who wins this round. I hope you have paid great attention to what Greer and Lucy have mentioned today. And let's test your knowledge and see how well have you all understood the presentations. That's great. I can see 6 players have joined in. And I hope you are able to see my screen, right? Which is the quiz screen. Yeah, okay. Yeah, only 7 of us. We are nearly 55 of us on the call. Come on, guys, participate for the quiz. Let's see how well have you understood IVDR and the presentation from EIT Health.
Sorry to interrupt you, but it says that participants exceed the limit.
Oh, okay. Oh, that's sad. It looks like everyone would have joined in together. All right, no problem. We will go on with all the participants who have joined in right now. And let's start with the quiz. So the question 1 is, what does IVD stand for? The options are in vivo diagnostics, investigational diagnostics, in vitro diagnostics, and inverted diagnostic. You have 15 seconds remaining to answer this question. What do you mean by IVD? You have options A, B, C, and D. Select the right option. What's up? Okay. Oh, everyone got it right. There are 6 answers to this question, and everyone has given the right answer. That's in vitro diagnostics. Yes. Let's go to this question. Yeah. So as of now, Julia has answered the first, so she has the highest points. Let's see who wins the quiz towards the end. Let's move to question number 2. When is the date of application for the IVD regulation? And your options are A, 26th May 2022, B, 26th May 2023, C, 26th May 2024, and option D, 26th May 2025. When is the date of application for the IVD regulation? You have 3 seconds to answer. Time's up. And yes, the correct answer is 26th May 2022. And let's see who is on the leaderboard now. Julia continues to stay on the leaderboard, and Sandra has moved from position 5 to position 4. Let's see who wins this round. Next question, question 3, coming up on your screen. How many partners does EIT Health have? This is something that Lucy had explained during her presentation. How many partners does EIT Health have? Options 100, 150, 120, or 90. It's going to be interesting to see how many of the participants remember the answers to this one. Okay, the correct answer is 150 partners. That's a huge network that EIT Health has. And Julia continues to be on the leaderboard, and Elaine has coming up. That's good. That looks like a tough competition going on right now. Okay, let's go to question number 4. How are IVDs classified? This is part from Greer's presentation. How are IVDs classified? Your options are on a list-based approach, on a risk-based approach, on a self-determined approach, on a rule-based approach. You have 4 options and 8 seconds remaining. Select the right option. And there we go, time's up. So the correct answer is on a rule-based approach. That's option D. And only one of us has got it right. So let's see who is winning. Julia has moved a spot down, and Barrett is coming up next. That's good. The leaderboard looks interesting. Moving to question number 5. How many EU notified bodies are currently designated under IVDR? Notified bodies have been quite in the talks recently, and this question is part from Greer's presentation. So your options are 4, 5, 6, and 7. That's a tough call. How many EU notified bodies are currently designated under IVDR? You have 7 seconds remaining to answer this question. Time's up. Oh, everyone got it right. Yes, there are 6 EU notified bodies currently designated under IVDR, and Barrett continues to stay on top of this list, and Julia has moved down, and Daniela is coming up, and Sandra is also giving a tough competition. Let's go to question number 6, which reads, how many UK approved bodies include IVDs within their designated scope? How many UK approved bodies include IVDs within their designated scope? Your options are 2, 3, 4, and 5. Yeah, Greer has also mentioned, please keep in mind that the questions relating to IVDs are all with respect to incoming IVDR. Okay, so there are 3. One of us has got it wrong and 5 of us have got it right. So yes, there are 3 UK approved bodies include IVDs within their designated scope. The leaderboard looks interesting. Let's move to question number 7. Question 7 is, which of the EIT supported successful startups recently raised a funding of 30 million in Series A starting round? That's a huge fund, and this question comes from Lucy's presentation. Your options are Proverum, Celio Medical, Velola. So make sure you have the right answer to this one. 2, 1. And the correct answer is Proverum. Yeah, all the 5 participants who got it correct. That's great. And to others who are unable to join the quiz, if you guessed it right, give kudos to yourself. Let's look at the leaderboard. Yeah, not major changes, but yes, the spot 4 and 5 have changed. Let's go to question 8 and see which class of CE mark device must be fully compliant with IVDR as from 26th May 2022. The date is coming soon, so you should know which class of CE marked devices must be fully compliant with the IVDR as from 26th May 2022. Your options are Class A, Class B, Class C, and Class D. You have 5 seconds to answer this. And time's up. The correct answer to this question is Class A. So Class A CE mark devices must be fully compliant with the IVDR as from 26th May 2022. Let's look at the leaderboard. Yes, there's some good changes coming up. Let's move on to next question, question 9. Why has the EU Commission brought in additional transition periods? And your options are: resources had to be diverted to address COVID-19, substantial changes introduced by IVDR, shortage of notified bodies designated under IVDR, and option D, all of the above. Well, I guess this is a very easy question, and all of you should get the right answers. Why has the EU Commission brought in additional transition periods? Well, the correct answer is all of the above. Definitely COVID-19, changes by IVDR, and shortage of notified bodies has impacted the implementation plan. Yes, and the leaderboard looks interesting. Barrett seems to take the lead as of now. Let's go to question 10 and see what happens next. Which of the following most accurately describe the role of a notified body? Your options are: to provide regulatory and quality compliance advice, to audit a manufacturer's quality management system for ISO 13485, to conduct conformity assessments under relevant EU directives, and the option seems to have been missing. And option D, to review relevant technical documentation so that a CE mark can be issued. Yes, the correct answer is option C, to conduct conformity assessments under relevant EU directives. Okay, interesting movement in leaderboard. We have Barrett on first, Daniela second, Julia third, Sandra on position 4, and Natalia on position 5. Let's go to question 11. Which class of IVD can be self-certified by the legal manufacturer? This is an important question, and there would be many manufacturers in this call or on LinkedIn Live. So this is a question for you all. Which class of IVD can be self-certified by the legal manufacturer? Your options are Class A, Class B, Class C, and Class D. And the correct answer to this one is option A, Class A. So Class A or IVD can be self-certified by the legal manufacturers. The leaderboard looks... Oh, there is a shift in the leaderboard. Barrett has moved down a spot and Daniela is taking the lead now. That's interesting. Let's go to question number 12. And the question is, where can you find a list of notified bodies designated under IVDR? Well, that's a very interesting, and this was towards the end of Greaves' presentation. And your options are UDAMED, UKFSA, NANDO, and USFDA. The question is, where can you find a list of notified bodies designated under IVDR? And you have 6 seconds remaining to answer this question. Let's see how many of us get it right. Oh, yes, Nando. Nando is the correct answer. So 4 of us have got it right, and also the people who couldn't join the quiz. Daniela continues to maintain the lead. Let's go for question 13. Is an EU authorized representative equally liable for directive IVDs together with the legal manufacturer? The options are no, sometimes, yes, and never. So the question is an EU authorized representative equally liable for directive IVDs together with the legal manufacturer? So definitely, we all know the answer, but let's see who gets on top of the leaderboard. The correct answer is yes. So EU authorized representative shares equal liability with as the legal manufacturers of IVDs. And Sandra has taken quite a leap, and she has moved from 4th to the 2nd position, but Daniela continues to stay on top. Let's go for question 14. This is the second last question. What is the estimated percent of IVD manufacturers needing to engage a notified bodies under the EU IVDR? Is this a tough question? Well, I don't think so. So your options are 25%, 50%, 85%, and 100%. So what is the estimated percent of IVD manufacturers needing to engage a notified body under the EU IVDR? Okay, the correct answer is 85%, and I'm sure all of us have got it right. Let's look at the leaderboard. Daniela continues to stay on top of the leaderboard, and this is the last question. Let's see who wins it towards the end. A very interesting question. What is SAMD? SAMD, and all of us belong to some or the other technological backgrounds, and we should definitely know these answers. Your options are supply as a medical device. Option B, software as a medical device. Option C, safety aspects of a medical device. Option D, software accessory to medical device. And the correct answer to this one is, of course, software as a medical device. Yes, two of us have got it wrong. Let's see the leaderboard. Okay. Well, yes, Daniela is the winner of this quiz competition. Congratulations, Daniela. You have won this quiz, and others who couldn't participate, I am sure you would have got the correct questions. Well, as per our time schedule, we are running a little late as compared to our time agenda. And now is the time for a screen break. So I would suggest you all can take a break, go for a cup of tea, a coffee, and take some break. We will be back here around 2:05. Yeah, we're going for a 10-minute break. So see you all back with David, who is going to speak about SAMDs. Till then, please take your breaks and see you soon.
I'm ready to start when you are, Jay.
Yes, hello, David. We will be waiting just for a few more minutes. Not minutes, but for a few seconds. David, I cannot see your video.
Okay, let me try and turn that on.
Yeah. Okay, David, I can see you now.
Right, you're going to allow me to take control of the.
Yes, I have stopped sharing my screen. And you can start sharing your screen. So till the time David pulls up his screen, I would like to welcome you all back from your breaks. I'm sure a little bit of tea and coffee would have energized you to get in some more insights. And David, I can see your screen. You can start with your presentation. Yes, that's perfect. So yes, David, first of all, yes, welcome back everyone after your break. And David is going to talk about IVD, software as a medical device, points to remember. So yes, over to you, David.
Okay, hopefully some of the audience are back from their break, right, to listen to my and Paul's speech. Okay, I'm here to talk about medical device software, okay, and how you design and develop it. Right, okay, so first things first, the software application environment. If there's now a requirement in the UK, right, and it's coming into Europe, that most hospital organisations would like your software to be either internet ready or ideally cloud ready. The emphasis behind being cloud ready is it then takes the emphasis of maintaining that environment back to the manufacturer rather than on the hospital. Right, okay, so you know, is your software digital healthcare rather than medical device software? There's a fine line to, sometimes there's a fine line to pick between medical device software, i.e. software that meets the definition of what an IVDR is or its accessories, versus some things in digital health, right, okay? As I previously said, you know, if you're going for reimbursement and acceptance in certain countries, and the UK is one of them, they would prefer your software to be cloud-based because that's your responsibility to maintain it. And people tend to use things like Amazon service. Right? There's a requirement in both the Medical Device Directive and the IVDR to consider cybersecurity, which Paul is going to talk about in his presentation. So I'll leave that to Paul. And Paul is also going to touch on things like the other environment outside medical device software, but has an implication for your software, such as data security and toolkit, cyber essentials, and being equivalents of those procedures and questions, because it's all about data governance and confidentiality of patient health information. Right, so as previously touched on by Greer during her talk, right, is your software, right, that you're developing or planning to develop a medical device, right? So there's a good guidance document that's being produced by the Medical Device Coordinating Group, like back in 2019, and that's document, you know, MDGC 2019-11 that can be found on the European EU website, right? Okay, and there's a definition in there for IVDR and IVDR accessories, right? So does your software meet that definition? If it does, then you can look at the information that's been provided. And as Greer talked about during her presentation, is your software analyzing data that comes out of an IDV product? Is it being used to drive that product? And there are A to F conditions that you have to try and meet, right? So for example, is it used to predict the treatment of a response or reaction? Is it used to monitor therapeutic measures? Is it concerning the physiological or pathological processes or states, etc.? So go back, have a look at what the IVDR says in the regulations, and have a look at what it says in this guidance document, and try and match up to your intended use. Right. If you are saying yes, yes, and yes, right, is the intended purpose substantially driven by IVD data source, again selected by picked out by Greer as being critical, right, then you're covered by the IVDR regulations. If no, there might be a chance that you're covered under the EU Medical Device regulations. Okay, if you're developing software in England, or sorry, in Great Britain, which is England, Scotland, and Wales, right? Okay, then you might want to have a look at the MHRA website for guidance, and they produce a very nice flow chart that is interactive as you go through it, right? To decide whether you are a medical device software. Because remember, we're still working under the old MDD, right, rather than the IVD. Sorry, the IVDD rather than the IVDR. Okay, the area that wasn't touched on by Greer, right, when she was talking about rules and regulations, and the reason for wanting to talk about this is that you could get caught out if your software, right, drives an IVDR product, right, or is implemented, right, then you have to be very careful, because if you thought your software is a class A and it drives a screening tool used for automated photo recognition, right, of cancer cells, for example, on slides, then your software would be the same class as that bit of kit. Okay, through these implementing rules, and this could cause your whole software development to have to go back and restart because you needed greater documentation. Okay, so for an example for this would be a slide-driven system. Hopefully, I'll come to that next. Right. So so if you looked at an ELISA analyzer, and it's intended to help you diagnose diabetes, right, and monitor patients with diabetes, right, then that would take your software up to a class C device under Rule 3K, right. If your software is within a PAP stained automated cervical cancer screening system, right, then your software would be classified under Rule Class C under Rule 3H, right. If your software is for the interpretation of automated readings of line immunoassay for confirmation determination of antibodies for HIV, then you'd be Class D as per Rule 1. So where the software is used, how it's used, has a direct implication on its risk classification. Right? Okay. Running in parallel with these rules is ISO 13485, right, which has a clause 7.3 about the design and development of software, and we'll touch on that on the next slide, right? But software is governed under an ISO standard, IEC 62304, right? This standard talks about software safety classification, class A, B, and C. So as well as having our class A, B, C, D for IVDs, right, you now have a software classification which has a class A, B, and C, just to design to get people confused. Right, where class A, luckily, is the lowest class, class B is medium risk, class C is the highest risk, right? By default, software starts off as class C, and then you work your way through this very simple flowchart to come out with a software safety classification, right? So obviously, if it can cause a hazardous situation, right, arising from the failure of the software, right, it's a right. Sorry, if it doesn't cause one, then it's a class A. If it evaluates the effectiveness of risk control measures, right, etc., it can either be class B or class C. Class C, if it causes a really severe injury to a patient. Okay, so there's an intermediate one, which is medium risk, a high risk one, where you cause serious injury to patients and no risk to patients. The reason why that's important is it then reflects into the documentation that we're going to need later on. Okay, so how do you develop your software? If you're going for 13485 compliance, which now 85% of IVDR companies have to do, there are 7 stages in the ISO 13485 that refer to design and development. Okay, so you start off with design and development planning. Okay, so how are you going to develop your software? Then you have your design input, so that's taking your user requirements and working out how you're going to do how you're going to split them up into design requirements. Okay, obviously the outputs are how you're going to deliver the final product. Then there's verification, validation, okay, which is how you demonstrate compliance that you've actually hit these things. So verification is design outputs equals design inputs. Validation is the user requirements to the finished product. Design transfer is a bit more complicated, or it's a bit simplified for software. It's how you deploy your software, how you take it out from the development environment and put it into the release process, right? Because software tends to be easy to distribute, right? Okay, and intermingled into that are key stages for design reviews at user requirements, design inputs, design outputs, at the end of the verification and validation stage, and at the end of the deployment stage. 13485 also asks you to have a medical device file or design history file. Okay, so going to the standard I had trouble pronouncing earlier, right, which is IEC 62304, right? This is this describes the software development life cycle. Okay, this life cycle covers everything from the creation of your software development plans through to your system documentation, your risk management, right, your software configuration, and then once you've released the product into the field, how you deal with bug fixes and software maintenance. Okay, hence it's called a medical device software lifestyle standard. Okay, right, this chart here is on the screen now to say that if you have a class A device, right, so this is software classification level class A, which is low risk. You don't actually need everything that a high, that a high risk product has. So yeah, you need a software development plan. Right, that's great. Right, so planning of software development standards, methods and tools, that's only required for a class C. So there's different types of documentation required for the different safety risks. Okay, and this is just looking at one of the clauses in the standard. So clause 5, for example, is software development planning. Okay, so in 62304, right, there are 5 main clauses. So you've got software development planning, software maintenance process, software risk maintenance, configuration, and software problem solving. Right, so what does that, so what do these grand titles actually mean? Right, so, okay, so under software planning, right, so you have software development planning, software requirement analysis, and architectural design and development of software, detailed software development, right, implementation and verification of software, etc. Right, clause 6, right, is about the maintenance process. How do you plan for it? How do you analyze the problems, etc. Right, clause 7, which is about risk management. Right, one thing you have to remember about software is it will always fail. That's the number one thing you have to remember with software. It's not like hardware. You have to assume that software fails 100%. So what have you done to analyze the software, to mitigate the risk? What risk control measures have you put in, and how have you verified it? And then once you release your product, how do you then keep the risk management up to date, right? Okay. Obviously, clause 8, software configuration management. That's about how you release your product out into the field and you keep your version control. Because medical devices aren't like Microsoft, so we shouldn't be doing constant updates all the time, where every time you power down, power up your machine. Medical device software has to be a lot more controlled. Okay. When you have bugs reported from customers in the field, how do you then manage that? And that's all defined under clause 9. Okay, so earlier on we had a slide that talked about class A, class B and class C. With the FDA, for example, they've turned class A into minor concern. Moderate concern is what we call a class B, and a major concern is obviously class C. And this slide just demonstrates that the FDA has a similar set of requirements as does IEC 62304 in terms of the requirements for different levels of documentation. Okay, so this is again a different portrayal of the 62304 standard, telling you what's sort of required under various headings. So in theory, you start off with the planning stage at the beginning of your development, and then you do your requirement analysis, your architectural design, detailed design, unit verification, software pre-release, program and integration testing, and software system testing. So there's a structured approach to it. Now you have to go, if you remember one of the previous slides that I showed you was the clauses in 13485, and we have to try and structure what it says in this standard versus a 13485 audit, where the auditors are saying, how have you developed your software? Where have you got your design inputs from? Where have you got your design outputs? We have to try and overlay the two. Between 13485 and 62304, there is no defined method of developing software. There are all frameworks, so each company has to work out how they hang their software development process onto these frameworks, right? And how they can then demonstrate that in a straightforward manner to manner to both an auditor, right, who's coming in under a 13485 audit, right, and then if you have to send your files off to a notified body to be reviewed, and they'll, you know, they want to be able to look in your design history and see that you've been through these steps, right? So one of the common methods of development now is the agile method of development. Companies are tending to move towards the agile or variations of agile because it gives, you know, greater customer satisfaction, flexibility to respond to change. You can break your software down so you have frequent delivery of working software, right? So it's a very iterative process during a development cycle, right? And even during a software maintenance cycle, right? You can get close cooperation with the stakeholders and the development and the developers, and I'll show that more clearly on another slide. You get clearer communication, okay? You get working software where you can start to do beta trials against and check to see if it's meeting your design requirements. It's sustainable development, and you're able to maintain this development at a more constant pace, because instead of having a software development cycle that would maybe be 10, 12, 20 weeks, right? You're doing everything typically in a 2-week sprint. So you get the impression that the software is moving forward, and you're continually self-assessing and through the sprint cycle. So here is a second slide. Right? Typically, you've translated your user requirements and your design requirements into something called a product backlog, right? And this has broken down your user requirements into detailed design requirements, and each one is given a PBI number. And then typically you choose a set of PBIs to go into a sprint, and that's what you're trying to implement within a 2-week sprint. One of the things we talked about was clearer communication with your stakeholders. So every day you have a daily scrum, right, with a scrum master, which is basically a team leader, and each developer will talk about the issues they're having or the progress they're making with their software. And at the end of a 2-week sprint, typically you have a review, and you then take that branch and you put it back into the main software. Okay, each company will implement this slightly differently, right? But the issue we've got is we've got to overlay this against either the 62304 standard and ISO 13485, right? And this is where Paul and I's expertise comes in. Okay, so how do you tend to do this, right? So in your PMI, right, you have your requirements section, okay, which typically can turn out to be the user requirements, right? Okay, and then a design requirement, and then you do a detailed design requirement. Okay, then you start to set your acceptance criteria. This acceptance criteria is forming part of the verification or validation plan, right? Okay, and then you typically you create a branch of your code, right? You do your development on it. After you've done a peer code review, you can then implement and you've done the corrections to that, right? You can then do an automatic build. You can do some automated testing. Okay, this is one of the reasons why Agile is liked by so many companies, because you can do automated testing down at the module level, and it gives you greater confidence in your software. It also helps to demonstrate verification, right, and validation. Okay, and then at the end you can commit it and build it back into the main system. And then the next time you do a sprint, you can repeat all the testing again and check that the new sprint hasn't upset the old code, and it's done under the automated process, so it doesn't take up much time. Okay, one of the harder things to show is demonstrating software traceability. So back under 13485 clause 7.32, there's a requirement to show that your user requirements have been translated properly all the way through the system. So you start off with typically you normally give a user requirement and a unique number. You have a description of what it here is in column 2, whether it's a requirement for the pilot or your first release, you know, what the system requirement is, a description of what the system requirement has been translated into, a unique verification and validation number. So when you verify that software, so it's part of the verification script. And here in columns sort of 6, 7, and 8 is which PBI that was built into and what the unique identifier is, so that when you're audited either through your technical file or during your 13485 audit, you can demonstrate how that requirement was met. The other sort of real bugbear in bugbear for all development systems, and for, you know, 13485, one of the things your engineers will talk about the most is, you know, having to produce documentation. Software engineers typically or generically aren't prone to wanting to write documentation, because actually what they're good at is writing software code. Okay, so with things like Agile, you have to be creative in trying to match up the requirements of 13485, like user requirements. Okay, translate that into Agile terminology. That's user story description, right? Acceptance criteria, which the engineers are used to, are actually can be verification planning or validation planning, depending how late you are in the cycle. Right, your code reviews, okay, which is part, you know, which the output of that would be a verification report or validation report, depending again where you are in the cycle. Automated test criteria, again, is part of your verification planning. Test poll results, you produce into a report, you pull it out of the database. Right, so the only extra thing that you're doing here, right, for 13485 is, right, and 62304 is doing design reviews at certain key stages. Okay. Okay, so that's just a very brief overview of sort of standard software development. As was mentioned by the first presenter, you know, software is moving on. You get AI into it, and or machine learning, and the regulations in terms of things like IEC 62304 haven't really caught up with the development of AI and machine learning, right? So the FDA and the MHRA and Health Canada came out with a set of good machine learning practice for medical devices, right? So they've come out with a set of golden principles that they expect people who are implementing either machine learning or AI embedded software, right, to go through. So they want a multidisciplinary team, right? They're looking for things like your data sets to be validated and unbiased, right? So if you work your way through this list, or if you want to come and talk to Paul and I to get practice and experience, right, to demonstrate how it's done properly, right, please feel free to talk to us. Right, so you've got good software engineering, security and practice. So that means looking at your supply chain and making sure that if you have software of unknown provenance, right, you know exactly where it comes from. So if you have a USB stack, so if you have a Bluetooth stack that you bought in to operate a wireless bridge, for example, where did that software come from? What has it got built into it? You know, are there any unknowns in that software? So you only need to look at the spate of FDA notifications that's come out in the last couple of months to see that, you know, there's been a backdoor discovered in Java. There's been a problem with Bluetooth devices having holes in them and people being able to exploit those holes, right? So knowing where your software comes from is just as critical as in the hardware world of knowing, let's say, where your where the motor that you bought in to power a slide machine, right, has come from, right? How do you validate those subcontractors? Okay, so all forms part of software development. So your choice of language is entirely down to you and your company. The way you develop your software is down to you, but you have to try and demonstrate that it meets both IEC 62304 or the equivalent standards for digital health, so there's an 82304, for example, or and then how do you overlay that on top of ISO 13485 clause 7.3? These are all areas that we can help you with. And now I'm going to hand you over to Paul.
Thank you, David, for some really amazing insights. And yes, thank you so much. And I would like to now invite Paul for cybersecurity under IVDR. Yes, over to you, Paul. I can see your screen.
Thanks, Jay. So as long as you can see the first screen, we're off to a good start. So welcome, everyone. Although my talk is titled Cybersecurity under IVDR, the cybersecurity topics covered will also underpin your data security strategies in any medical device development environments you have in your organization. And in fact, the NDG cybersecurity standards apply to any business wishing to harden their data security. So today, medical devices, the data they collect and the systems they are developed on are without doubt now a target for cyber criminals. Whether they are organised crime, nation state backed, or low-level opportunists who stumbles into your network. They may not wreak havoc on your systems. It is more likely they will install ransomware or malware. Either way, a breach will bring risk and damage to your company's systems along with your reputation, particularly if sensitive data is exposed. So an example being quickly is in 2017, WannaCry ransomware attack on the UK NHS was resulting in many thousands of appointments being cancelled. So it pays to mitigate the risk of your digital systems being exploited. One of the main sort of mantras of anyone in cybersecurity will be CIA, their point 2 on the slide, which is your data confidentiality, integrity, and availability. You've got to always maintain that. So cybersecurity, it's all about mitigating those risks, but where do you start? So for the UK market, the best place to start is the National Data Guardian Standards, NDG. And introducing those requirements and standards via policies into your organisation will go a long way to securing your environment and digital product developments. An FYI there is the NDG advises on the state of information governance across the healthcare system in England. These are the 10 NDG standards and the topics they cover. And your cybersecurity policy should reflect the requirements of each one of them. Using these standards for the UK will also benefit you when completing other countries' data security and protection assessments. What I mean by that is that you will notice really across the US and Europe and the UK, cybersecurity is pretty much the same. So that's why I'm saying that these standards that you would use in the UK will be useful to you if you apply them, and then when you're selling your products into EU or into the USA, you'll have covered a lot of the areas of cybersecurity that those authorities will be looking for. So if you're planning on selling products in the UK, I would suggest you start by aligning your data security policies with these 10 standards. So how does introducing these standards into my organisation organization's policies help me, is what you're asking, I'm guessing. Well, it puts into place a solid foundations for your cybersecurity strategies. And they certainly are strategies. So these are the cyber assessments and certifications which you'll be required to attain if you are providing digital products into the NHS. And by implementing the NDG standards into your organization's policies, you will be not only be including the necessary cybersecurity requirements to the UK assessments, but also they will satisfy a majority of the criteria required by other international assessments and standards. These are a number of the new ones that we've just been looking at for various people. They all require a lot of evidence, all of them. So the first one that I'm bringing up here is the DSPT toolkit. It's a single standard that all organizations with access to NHS patient data and systems must adhere to. Currently, we're using version 3. However, version 4 is due on the 30th of June this year and may well have been tweaked to include more requirements. So the DSPT assessment journey. Of those 5 points, there's a few of them that do stand out that I wanted to draw your attention to. Point 1 is it is important, as you will need to ensure that everyone in the organisation commits to the policies. So you do need the board's backing. After all, they'll be financing all of the work that you've got to do to implement them. Point 3, as I think we've mentioned, both Greer and both David have mentioned, evidence. Start collecting evidence as soon as possible, showing that you are following the policies fully, as a DSP assessor will use this evidence in their assessment of your organisation's ability to secure and protect data. And point 4, gap analysis. It is important to get a review of the policies and evidence text against requirements of the DSPT prior to the assessment submission. The gap analysis reminder really applies to all potential certifications and standards that you wish to attain. It makes life a lot easier if you've already compared what you've got to what's required prior to you getting someone in to assess you. It will save you a lot of money in the end. Okay, UK Cyber Essentials. So since the 1st of October 2014, the UK government requires all suppliers bidding for contracts involving the handling of certain sensitive and personal information to be certified against the Cyber Essentials scheme. And note that is undertaken each year. On there, if you're wondering where the NCSC fits in, they are part of GCHQ, our government communications headquarters. So they consist of 5 technical controls. Bear in mind, if you've been implementing policies and collecting evidence text for the DSPT assessment, then that data can be utilised also for the Cyber Essentials and possibly some EU assessments as well. For instance, Germany's BFARM assessment. In-house web applications are not in scope for the Cyber Essentials assessment. However, for other assessments you may well have to take, they are DSP for instance, and you will likely need to demonstrate that robust testing has been done in line with the Open Web Application Security Project, the OWASP guidance. So the journey for Cyber Essentials. Initially, you can use the free Cyber Essentials Readiness Toolkit, where your answers to the toolkit's questions are used to produce an action plan to help you meet the Cyber Essential requirements. A rough costing, though, for the self-assessment would be £300 plus VAT for a micro organisation, rising to £500 for a large organisation with 250 employees. So the idea really is to take the free Cyber Essentials Readiness Toolkit, take the questions, and those responses will generate your action plan. You'll then go and implement those actions, and then you'll need to agree the scope of your IT infrastructure to be assessed with your assessor. It's important to agree exactly what the boundaries are, what he's going to look at. For the self-assessment, you will need to provide evidence that the requirements have been met, and if they are met, and if the assessor agrees, then you'll obtain your certificate. One thing you need to factor in, though, is that you'll need to factor in the cost of preparing for the assessment and aligning your practices. So you've got the cost of the self-assessment, depending on your organisation side, plus prior to that, factor in the cost of preparing this for the side, preparing your policies and practices. Hence, you need the board's approval. Right, there is a second certification, the Cyber Essentials Plus, for those of you seeking a higher level of security. To be eligible, you must complete the audit within 3 months of your Cyber Essentials certification, or take both simultaneously. It's a little tougher, and it would be wise to prepare with a gap analysis as well as running your own vulnerability scans or seeking this service from a third party. The certification process comprises of a technical audit of your systems, an external vulnerability assessment, an internal scan, and an on-site assessment. The test cases displayed are typical of the type of verifications the assessor will carry out. DTAC, right. That was mentioned earlier by David. This should be prepared by a suitably qualified clinician. The DTAC introduced by the NHSX is designed to introduce a new national baseline criteria for digital health technologies entering into the NHS. It will be used to assess suppliers at the point of procurement. The NICSF is a set of evidence standards which have been developed to help technology developers collect the appropriate evidence to demonstrate clinical effectiveness and economic impact. The aim to promote consistency in the way that DHTs are assessed across the NHS by health technology assessment organisations and commissioners. I think that's to prove, to show that you were all working from the same point. It makes it a lot easier for the buyers to assess you. So the clearer the evidence standards that you've got, the clearer the evidence is, the better it is for you to get the product into their trust or their organisation. So the DTAC 5 core areas are clinical safety, data protection, technical assurance, interoperability, usability, and accessibility. So what we have there is clinical safety, though the products are assessed to ensure that baseline clinical safety measures are in place, and that organisations undertake clinical risk management activities to manage this risk. You have data protection, so the products are assessed to ensure that the data protection and privacy is by design and the rights of individuals are protected. Technical assurance, so the products are assessed to ensure that products are secure and stable. And interoperability, products are assessed to ensure that data is communicated accurately and quickly whilst staying safe and secure. Usability and accessibility, so the products are allocated a conformity rating, having been benchmarked against good practice and NHS service standards. So we have European cybersecurity certifications. So there are a number of other schemes across Europe. And when combined with the international standards such as ISO 27001, it can make it difficult for organizations to accurately assess the cybersecurity risks associated with a potential provider's products and services. So because of that situation, we have the EU Cybersecurity certificate framework. This is fairly new and enables consumers to make better informed decisions about products, processes, and services they use. The framework sets EU-wide parameters for rules, technical requirements, standards, and procedures surrounding risk-based certification schemes covering different categories of ICT products, processes, and services. This harmonized approach to cybersecurity certification will supersede member states' individual certification schemes from mid-2021. Sorry about that. Okay, so the harmonized approach to the cybersecurity certification will supersede member states' individual certification schemes from mid-2021, although certificates issued under them will be valid until expiring. Okay. Here I'm just really showing you what are the certifications are waiting out there. This is Germany's way of prescribing a digital application. It may not apply to all of you, but I thought I would include it. The BFARM assessment roughly takes into account all those requirements that the DSPT outlined. Thus, it requires evidence from the manufacturer that the health app is able to provide positive healthcare effects. So what I was trying to show there was that if you're doing a lot of the standards, like I said in the beginning, are sort of very much the same across Europe and across the US, the cybersecurity part of it. So if you've put a lot of effort into the DSPT, for instance, you're going to be able to sail through some of the others because you've got all of the information you need for cybersecurity, for cyber essentials, and the BFRM. So right, so I wanted now to draw your attention to the ISO 24971, which is the medical guidance on the application of the 14971. So Annex F of the 24971 provides guidance on risks related to data and system security. A common misconception is that ISO 14971 would only apply to the health of people, disregarding that the definition of harm includes damage to property and IT and the IT environment. So we should be looking at not only risks related to the patient, but also risks related to security. So looking at the flow, you will see how with the loss or degradation of confidentiality, integrity, and availability, we are now open to a vulnerability being exploited by threats, as shown on the right-hand side. That's just a selection of threats, by the way. It's not the absolute list. The exploit now has the potential of developing into a hazardous situation with the probability of it leading to harm. The probability of the occurrence of harm coupled with the severity of harm is a risk we have to prevent or mitigate. A simple example of a hazard could be as follows. Let us consider a loss of data integrity. So due to the exploit of an unnecessarily opened network point, the dosage setting of an infusion pump on that network is modified by unauthorized access. So that incorrect dosage data leads to the infusion fluid not being delivered as intended, resulting in a deterioration of health of the patient with serious consequences. So you can see how these things lead on. The network port exploit could easily have been used to deliver ransomware on your system, encrypting important data and making it unavailable. So this is your ransomware where people want you to pay them a fee in order for them to release your encrypted data. There's a thing now called double extortion, which is they make you pay twice because they made you do it once, so why not make you do it twice? Here is where an effective vulnerability management system utilizing a vulnerability scanner can scan and detect security issues within an organization's network. It can also cover areas such as a patch management, and hardening procedures. There are a number of scanners on the market ranging from open software types to licensed products for enterprise systems. Obviously, when you get to enterprise systems, they're very expensive. So you'll see in the summary that I've included the 2017-746, the IVDR, but not forgetting the 2017-745 MDR, both of which replace the previous three EU directives. Remember, the previous directive pertaining to in vitro diagnostics will end in May 2022. And so start looking towards the IVDR now if you haven't already. And I will add the MDCG 2019-16 Revision 1, July 2020, for guidance on cybersecurity for medical devices. It's a very good reference. Certainly for the UK assessments and certifications, ensure you start collecting evidence texts related to security policies that you implement as soon as you can. So, finally, today I've tried to give you all a taste of regulation, certification and certifications around cybersecurity. It is a very big subject to cover in a short session. It can seem like a very large mountain to climb. However, there is help out there, and we hope we can play a part in helping you achieve your cybersecurity goals. Thank you for listening. Thank you.
Thank you so much, Paul, for enlightening us with cybersecurity under IVD. And the last slide of the summary summarizes the entire of the presentation. So thank you once again. And now I would like to pass this on to Celia from EIT Health Alumni Network. And Celia, over to you now. Celia, yes, you are on mute. Yeah.
Sorry, trying to unmute myself. Can you hear and see?
Yes, yes.
So thank you very much. My name is Celia Cruz. I'm really happy to be here today to present you the EIT Health Alumni Network. I mean, you have been here learning a lot of things about IVD, and I believe this has been truly insightful, especially if you're a manufacturer or if you're learning this on IVD in early stages. So what EIT Health Alumni can be to you, it's to be a community where you can learn from the others. But so first things first, as you have been presenting and assisting to this presentation, so you're able to join this community, this amazing community of EIT Health Alumni. And what is this? So EIT Health Alumni is a multidisciplinary community, so of engaged and innovative people like yourself that are leading the European ecosystem and shaping healthcare innovation throughout Europe and in the end throughout in the world. This is a community made by alumni and for alumni, and in that sense we are all of this is made by a community of volunteers. For example, we have here the board where I'm still included. We are also supported by a great network of local representatives and another very engaged alumni throughout all the different regions that Lucy in the beginning mentioned, that there are hubs there from EIT Health. So Lucy mentioned in the beginning that we were a network of more than 1,600 members. We are now more than 2,500 members, so we have been growing a lot lately. And what we offer to our alumni, you have the opportunity to learn several things, have activities. For example, we have even some initiatives that I'm also leading on regulatory part. Let's Talk Regulation, for example, have also ability to learn from other innovators and CEO. For example, I also have coffee with the CEO. You get to learn from the community. You can also have the ability to teach, so participate in these sessions from one side or the other. Have the opportunity to co-create with other people, of course, network, which is one of the biggest brands of our community, and of course hire or get hired depending on what you're looking for. To that, we have a platform that was launched already 2 years ago, and it has been growing a lot since, where you can just start by seeing our members and our network, where are they scattered, and eventually even speaking with them. You can see all our next opportunities and events, or even suggest new ones. For example, you have some event that you think the community could benefit from it. You could add it here, and you can see the opportunities that were tailored for you, for our community of alumni. Of course, you can track your own EIT Health journey and check other people EIT Health journey, where you can just see all the activities that you have participated, if you have participated in a lot, or just look into people that have participated in some other activities that could be interesting to you. We have also some groups where you can have get the most of them. You can talk to people, get to understand what is interesting for that, for example, for specific regions or for a specific topic. We have both of them. For example, we have one for boot camps, for the boot camps that existed. We also have divided by the different regional hubs from EIT Health, and you can get the most of it and get to talk with and network with other people, especially now that we are still in a very digital world. You can also find the next steps in your career, and of course, the other side, if you're looking for someone that you may find within the community, we are really happy to provide this another tool to find people or to get hired from within our community, or even from EIT Health. You can also, being part of this network, and if you have a startup, with, I believe a lot of you here have, you can also access the new EIT Health Startup platform, where you can claim your profile, gain visibility, and also if you're seeking funding, you can also have that and showcase there. And of course, you can access everything that from EIT Health alumni, our community, and our events that we have created. If they are digital, we have a record from them, so you can get access to this online content and check it out. So you can meet the community, you can get inspired by experts, you can learn from other experts depending on the activities that we have. You can go to our community rewind and look out for it. For example, if you're interested in regulations, like something from these sessions, we have the group from Let's Talk Regulation sessions. We have talked on topics on how to start from the regulatory process, even the FDA. We have not yet done one on IVD, but I believe this one was very interesting in that sense. But you can go there and check what else has happening there. That's one of the topics that I've been leading on. And also, if you have some suggestion of something you would like to see talked about, you also feel free to suggest or even talk with us on that sense. And now, just very quickly, what it's like to be a member, and this is my perspective, how it has been from my side. I am like an ancient member from EIT Health alumni. I have participated in the first summer school that existed from EIT Health, and I was there when we were launching the EIT Health alumni network. And since then, I tried to take the most of this. I've participated in several EIT Health activities, so fellowship, the Starship Fellowship, some activities focused on women entrepreneurship, participated in several EIT Health summits, and with that also started from the alumni side organizing activities, organizing workshops, network a lot. This was when I was, for example, in my personal case, I was finishing my PhD. I was trying to enter into the industry and into the more entrepreneurial world. And that's how I made this connection, this change. Since then, I enter into these regulatory affairs worlds, and I even organized some workshops concerning CE mark, some other summer schools where I mentored on this regard, organized several other events, mentor startups in this area. And this was also while I was entering to this side into the regulatory affairs world, even started my own consultancy company in this area, Compare Health, and where I'm also supporting small companies and startups in this sense, especially in software in medical devices and software as medical devices. There's many more to come. This is just my example as a member, how EIT Health alumni has shaped my path so far and has supported me along the way, and while all the different parts that I needed within my life. So I expanded my network, collaborated with several EIT Health initiatives from EIT Health. I have mentored, and I have also received some mentoring from several other people and startups. I connected with several early stage projects, and I'm boosting the community with new initiatives. So there are a lot of activities coming up next. I suggest you to just grab your phone, scan this QR code, or just go to the link that I also shared within the chat, community.eithealth.eu, and you can join there, check out what is there, connect with everyone, connect with people, and of course, if you have any doubt, I'm always happy to connect with you and answer any questions you may have. So thank you very much. Now I pass the stage to you, Jay.
Yes, thank you so much, Celia, for giving this interesting opportunity to all our attendees. And I'm sure all of them attending us on this class and also viewing us on the LinkedIn Live session would be interested in doing and joining this entire alumni network. So yes, guys, if you have any questions, feel free to drop them in. And now I would like to pass this on to Greer Deal for question and answers. We have went a little bit over time, but let's see how many questions can we pull it up.
Okay, so thank you very much, Jay. Got a couple of questions here. Someone's asking about guidelines for different types of in vitro diagnostic solutions. If we're talking about guidelines for the different types of diagnostics and the regulatory requirements that you need to comply with, I would suggest that the Medical Device Coordination Group, MDCG, if you search for that, they have a lot of guidance, and they are the ones that if you keep an eye on, they will send out updated guidance. So so that's a good source for guidelines. I mean, obviously you're going to have to do a bit of bedtime reading with regards to the IVD regulation. So I don't know if David, if you wanted to add anything with respect to where you can find guidelines from. David, are you there? You're on mute, or? Okay, I won't take up time.
Okay.
Oh, David, you're there. Okay.
Yeah, as usual, I was talking to myself, right? Okay, guidelines. Like you say, the best place is the start with is the MDGC guidelines for software as a medical device. Following that, the FDA have guidelines on software development. Okay, they are quite old, but they're still applicable, and depending on what type of software you're developing, if it includes AI and machine learning, they've got some more recent stuff that came out at the end of last year. Or the other approach is to reach out and communicate with Jay or Greer, and she can put us in touch, and and we can help you along. Okay.
Thanks, David. And there's another question here about with regards to the new IVD regulation. Is it actually coordinated with other EU regulations such as the Medical Device Regulation and the Data and AI Acts? David, I'm going to put you on the hot spot again.
Well, both the IVDR and the MDR are obviously coordinated, right? Okay. If you're handling any sort of form of patient data, that's also tied in with the GRPD. I think that's the correct, yeah, for confidentiality, right? The regulations are interlinked, and a notified body, if you're having your product review, will have expected you to know what standards to apply. And when you're doing your EU declaration of conformity, you have to list all the directives or regulations that you're meeting, right? And that includes all the current ones, right? Okay.
Thank you very much, David. And I think time for one more question, Jay, do you think?
Yes, we can pull on one more question. And the question is that how do you break the chain between combination products for inhaled therapies, inhalers, and the API canister?
So I think what the question is referring to here is we're talking about a combination device. So you've got a medicine and a device. So which is the overriding regulation? So I'm not quite sure about how you break the chain between the two because it's a combination device. David, did you want to comment on that?
Thank you for passing the bomb across to me. Right, okay, I'm sure it's going to explode on me in a second. Okay, but you can't really break the chain. You have to remember that they're interdependent, and you have to do your technical file accordingly, right, and bring both together. Because at the end of the day, from the regulatory and user's point of view, they want a device that is safe and effective. So it has to meet both sets of requirements.
But also, as I understand it, the European Medicines Agency is getting involved now when there's a medicinal aspect to a device.
That's right.
Yeah, exactly. So that's a new aspect that's come in with the new regulations. Okay.
I was just checking the LinkedIn Live section, and when I have a question there, like the question is, from where do you get a PRRC, and why is it necessary to get a PRRC?
So a PRRC should actually be an integral part of the company. But if the company is too small, i.e. they're a micro company or a small company, as per the EU Commission definition, which you can Google if you want, then you can actually outsource that role. And the role of the PRC is something that Medidia and Ireland can offer, as well as global regulatory services in the UK. There is no central list of PRRCs. It's literally approaching, doing a search and seeing who you can find. But I can definitely say that we can offer those services.
Okay, well, that's it. And I don't see that there are any more questions from the audience who has joined this class. Well, that's all for today, guys. So thank you so much to the panel members, to Lucy, Celia, Greer, David, and Paul for organizing and giving us your time and enlightening our audience. And definitely a big thanks to all the participants who joined in to get some insights on IVDR. And guys, just to mention, if you have any questions, feel free to drop them at mdd@mddldd.com. That email is there in the chat box, and our team will be happy to answer them. And do not forget, right after this class, I am going to send you out an IVDR checklist. So make sure you fill that up and be IVDR ready. If you have more questions on the checklist, again, drop us an email at mdd@mddldd.com. Well, that's it for today. And thank you so much to our panel members and all the attendees on all different platforms. Thank you, take care, and stay safe.
Thank you, Jay.
Yeah, thank you, everyone.
Bye, everyone. Bye.